So I'm thrilled to introduce Dr. Shannon Leon, who will be discussing functional neurology and functional medicine align. He will be discussing how to improve your daily functioning and quality of life while undergoing or completing cancer treatment. In this talk, he'll address preventing falls, improving balance, decreasing nausea, decreasing dizziness and vertigo, reduce chronic pain, peripheral nerve rehab, improve range of motion, and spinal biomechanics, enhancing independence and quality of life. Dr. Shannon Leon is one of the world's leading functional neurologists and wellness experts. He's a fellow of the American College of Functional Neurology and a fellow of the American Board of Vestibular Rehabilitation. He's a board certified in functional neurology, recently completed a fellowship in traumatic brain injury, and is concurrently finishing a PhD in nutrition. With over 15 years of experience in clinical practice, Dr. Leon is renowned for his extraordinary abilities in neurological assessment and cutting-edge treatment strategies without the use of drugs or surgery. His caring, compassionate nature and world-class service provides a unique experience for patients from around the world in need of improved quality of life, health restoration, and hope. Thank you so much for joining us today. We are very lucky to have you, and the floor is yours.
Wow, Jillian, what a beautiful introduction. Thank you so much. First, I want to thank everyone that's here today, that's joining us in person, and that'll be joining us in the future via recording, on demand. My main goal of today's talk is I want to lift you up from wherever you are, whatever you're suffering through, and increase your level of hopefulness as to what's possible, and increase and inspire that better days are in front of you. And we're going to go through strategies for that, and it's going to look different for everyone. I know everybody is starting from a different point of view, a different point in their treatment, a different diagnosis maybe. All right, so I'm not talking to any one diagnosis here. I'm talking to what we can do as people to improve our quality of life from wherever we are, and then to shift our mindset that we have great days in front of us. Okay, so that's going to be a big thing, because the mind cannot be separated from the body. And when we look at that, the mind cannot be separated from the body. We want to then start using the instrument of the mind to allow us a degree of hopefulness that in spite my suffering, tomorrow may be better than today. In spite my nausea, I'm excited to feel a bit better tomorrow and maybe enjoy my favorite meal. In spite of my balance being off, I look forward to improving it so I can play with my grandkids better. In spite of my vision being off or my body aching, I'm excited that maybe something can be done to make my body move or function better so I can enjoy, a best friend, or, getting out of my house, or going to a walk on the boardwalk by the beach. It'll be different for everyone, all right? But the standard and the message will be for everybody, okay? So first, what are some of the most important things in getting someone to have a better quality of life in any circumstance of suffering? The most important thing is to make sure that we don't fall, right? And I know that sounds silly, but fall prevention becomes life-saving, because for so many people, whether they speak it or not, if their balance is off, if they have dizziness, vertigo, double vision, they may be very scared that they're going to fall and not want to leave their home. And that not wanting to leave their home then has secondary consequences into, can I do this? My birthday's coming. Can I meet my best friend? A holiday's coming. Can I meet at a family or friend's house? Am I going to be okay to get there? And then if they start feeding into that and not even trying to get there, maybe there's a sense of despair the mind kicks into and limits them further than they had to be limited. Oppositely, what if we can regain our confidence in being stable in balance, stable in stance, stable in walking, right? Stable in transfers from our bed to a couch, to a bench outside, to a car, to a restaurant, etc. Would that give us back some quality and some freedom? And the answer is very often yes. So fear of falling is a very real thing, and we see it very daily. And, falls are serious injuries that complicate all forms of treatment. So we take that very seriously here, in the sense that we look at, if you can prevent a fall, you can save a life, and you can also enhance someone's quality of life if you restore their confidence and they no longer fear falling. Okay, so the first thing we're going to talk about, and it all ties together, is preventing falls, improving balance, reducing dizziness and vertigo, and also nausea also ties into this reflex as well. And many people, through various forms of treatment, either before, during, or after, have a degree of dizziness, a sense of instability. Maybe their vision is a bit off, or they feel a little bit mentally foggy, and there's a degree of nausea or unsteadiness, all tied together. I'm going to start by just showing you how easily the balancing system, for those of you who know a different word, it's also called the vestibular system, but how our balancing vestibular system can work, be tested, and figured exactly where it's impaired or weakened, and how very easily it can be restored back to strength to give us our confidence back in stance and walking and gait, okay? So I have a little model here, and I have a couple of cute models. Maybe we use them, maybe we don't, but this one's cute. This is your inner ear. If everyone can see that, it's this little snail-like structure, which kind of really looks like a little snail. And as we sit it inside, we have one on each side. It sits inside the ear, inside the skull itself. And look at this as your rate sensor as to where you are to gravity in the world itself. And if we can look carefully, I don't know if it comes up clearly on the screen, but there's 3 central loops, and then there's a little processing station in the middle. So we'll say, for ease, there's 4 parts of each inner ear balancing system, okay? So if someone's saying, you know, doc, I'm falling all the time, I'm very scared to walk unassisted, I don't want to leave my house because I feel very unsteady. The first thing we'll do is we'll assess their balance, and we'll assess the 4 different components that make up balance on one ear to the other. And I'll show you that in just a second. And then figure what part of their inner ear balancing mechanism has gotten weakened, either through aging, different diagnoses, different treatments that they may be undergoing, various reasons, and then apply a treatment exactly to that part of the inner ear to very quickly strengthen that part of the inner ear to feed rate sense of where my body is in gravity to the brain and allow me to stand confidently again with my eyes closed, with my eyes open, walking around, moving around the house, not fearing falling anymore because we feel well-oriented, well-grounded. And then what happens with that is our mind gets clearer, a lot of mental fogginess goes away, and a lot of nausea goes away. So if we have these 4 apparatuses on each side of our ear, we'll have a patient either on a balancing platform. If they're not steady enough, we'll do it directly on a firm floor, right? And we'll have them first just stand with their arms at their side and close their eyes. See what the general sense is, right? Do they immediately fall? What direction do they fall? Do they just have a sway back and forth, but still can maintain some uprightness? You know, are they moving a little bit side to side? And look, is there sense in the direction that they're moving? Or is it kind of a bit of nonsense pattern from a lot of other inputs? We want to just figure that. Then to isolate out the 4 parts of your balancing system, we'll tilt the head to one side, close the eyes, and measure the balance. We'll then compare it to its tilt to the other side. Do we maintain balance and coordination? Or do we fall and become unsteady? Right? Next, we'll turn the head a little to the side with our chin up. We can also then test that balance with our chin down. Going to its opposing side, a little bit to the right and chin up. And then again, a little bit to the right and chin down. And we can also test the pure horizontal. Person turns to the right, person turns to the left. Depending, we'll write down every place that the balance was good, and then write down exactly what tilt of the head makes them fall. So then the therapy becomes just strengthening the exact portion of the inner ear that's mediated to their fall. And the inner ear is firing up information to the brain roughly at 1 million cycles per second. So it's one of the fastest information systems we get of our senses, that and our vision. We'll get into our vision secondly. So when we start just figuring where the balance is failing, and then our therapies go to that portion of the inner ear complex that's failing to update where we are in space, allowing us to fall, they immediately get steadier. And it happens like literally within a few moments. And with just doing some different strategies, often in literally a handful of moments, the patient will be able to stand, hands at their side, feet together, eyes closed, and not be falling. And for them, that often brings tears of joy because it frees them to leave their house. It frees them to start interacting with their family members. And at a barest minimum, it gives them that first degree of hopefulness that, wow, yesterday I couldn't stand without falling. Today, I'm able to stand without falling. Maybe something more is meant for me. Maybe I do have good days in front of me. Maybe there's hopefulness. Maybe there's a positive outlook that comes in the entertainment of, I could go to my favorite restaurant for my birthday. Maybe if I keep going forward and get stronger and stronger, maybe I could take a trip and visit grandkids, and on and on. Okay. So there's 8 portions of the inner ear. Inner ear communicates with the brainstem. It integrates up with our visual system. It integrates downward into our body for our posture, stance, and spinal reflexes. So when people are often feeling very unsteady and unstable standing, they'll often has a secondary consequence of joint pain because of the joint's instability, that the inner ear unable to properly control balance and stance and our ability to move in all positions and stay upright. If I can't do that, well, I probably can't influence my proper descending spinal muscles exactly in ratios to keep me steady as to why I'm falling or becoming unsteady. And if I'm pulling on some muscles in one direction and not equally on the other in regards to our spine will become misaligned over time. We'll have new motor memory, new muscle patterns. You may see changes in your posture. You may see changes in the way you slouch or the way you stand. You may see a head tilt. You may see a head carriage forward. And all of these things over time can create more frictional planes on our spine with movement, with stance, with everyday activities, and end up increasing our amount of joint pain, stiffness, and suffering, which then compounds the issue that if we feel stiff and painful, and then we also feel out of balance and they're married together, then again, we may lose our want to leave the home. So if we can stabilize the inner ear and get the inner ear functioning much better, and we can then get much better output of the inner ear through the brainstem, through our spinal components, through our peripheral nerves, to our muscles to hold new stance, new posture, new spinal alignment, will often have an influence of a lot less spinal pain, increases in range of motion with stability, which again, you wake up the next day and you say, you know, yesterday I was much more achy and stiff and I was off balance. Today, I'm standing, my balance is much better. Wow, look how nice my posture is able to hold itself. And when I'm moving, a lot of my pain is relieved. Okay. And again, I'm not talking about any specific condition or diagnosis. I'm talking about just being human and how our body works, really because of how our brain works. And then by subtle changes to the brain, by playing on the inputs to the brain through balance, spinal motion, or vision, which we're going to get into in a moment, we change all the parameters of how our brain, as our supercomputer, controls all the functions of our body through its own software. And you ask, what kind of software is that? It's not Windows or, Apple iOS. It's mathematical algorithms as to where we are in space visually versus where we are in space from a rate sensor to gravity versus where we are in space from all the feedback from our muscles and joints when we're standing in weight bearing. So those 3 systems, somatosensory is the fancy name for it. It's the feedback of all your muscles and joints, right? And all that information from your body. Vestibular information from your rate sensor of your inner ear, and visual information. Where are we in the world visually? When these 3 systems, somatosensory, my body's joints and posture, my inner ear, my vestibular system, and my visual, the way my eyes move or work, which I'll talk in a second, are in a 1-to-1-to-1 ratio, we have resolved dizziness, vertigo, visual imbalance, spinal imbalance, a lot of pain. And because the net integration is in a layer of the brainstem, for those of you familiar with it, called the pons and the medulla, that primary integration site also holds your vagal nucleus, which has a lot to do with gut function and bowel movements, and the nucleus tractus solitarius, which is the main thing that controls your perception of nausea. So if we can balance the brainstem using vestibular, body, and visual exercises, well, then we balance the brainstem, which then relieves nausea without any anti-nausea drugs from a control center of the computer telling its function, you no longer need to express to the body nausea from the imbalance of ear, body, and eye. I now am balanced in those three information relays, resolving my nausea. Okay, so I'm taking you a little out of the box to show you that there's so many forms with this advances in neuroscience and functional neurology that drastically change quality of life in really any diagnosis, in really almost any circumstance, and with non-pharmacy, non-drug. And because it works so profoundly, we've been blessed to have patients from all over the world come here for the unique strategies that we do for therapy. And what I get especially jazzed about is that when we're doing the non-pharmacy side, someone else is doing the pharmacy side, the results are certainly, brand new to the person. And they're very life-changing because it's really never been done. We're starting to see the first time in history, the mergence together, the teaming together of the best of all specialties to create one standard product for patients to say, hey, you're a whole person. You're not the label of your diagnosis. You may have this certain condition that you're working through, but that's not who you are, right? So we want to start changing that fundamental view of how we see ourselves. And in doing that, again, it opens up the doors for hopefulness and inspires that a positive outlook. I have good days in front of me, and I'm going to dare to believe that. Okay, getting back to your visual system now. The eyes are super, super important. Okay, why? Because it's constantly measuring the length of view to any target in the world that you see and planning how to activate all your muscles in such a way that when I go to reach for a cup of coffee, I can grab the actual handle and then gently bring it to my mouth and have a sip and not pour it and spill it all over myself. Or when I go to reach for the cup, I don't have an error in my depth measurement where I go to reach for the cup and I knock it right over and it's on the floor, right? So visual alignment, visual tracking, visual trajectory are all super important to having the reversal of mental fogginess, where we feel a little cognitively impaired in a non-diagnosed way, meaning non-dementia, non-Alzheimer's pre-diagnosis, right? And many, many, many people describe fogginess for a host of reasons. And the majority of it comes from the mismatch of our visual system to our vestibular system. So how do we measure that? Very simply. First, I like to look at the speed of the eyes, right? Just to get a window of a whole hemisphere, one whole half of the brain, comparing it to the other whole half of the brain. And if I just put up two simple targets, like my two lucky thumbs, and if I have a patient say, look here, go back and forth 3 times as fast as you can, what if they can go here really fast, but they go here super duper slow? Well, if they go here super duper slow, I know this whole opposing opposite-sided hemisphere is really electrically reduced in its output, having very little oomph to push the eyes to its opposing side. So then it gives me, just my very first measure, a window potentially into the sidedness of treatment, so that we don't try to treat every little thing of the body and hope that we balance it. No, we measure the portions of the brain through its balance, through its spinal motion, through its visual features, to figure out where is the brain not working correctly to control its body, which produces symptoms of dysfunction that we perceive as suffering, and how do we correct that imbalance and do it exactly. So if we isolate out, the patient's very slow to bring the eyes to their right. Well, I know that we're in their left brain, and more particularly the left frontal lobe, left midbrain, for those of you familiar with it. So we're going to be doing right-sided therapies with them in the office, so that we don't want to do therapies on both sides when one side is grossly overperforming the other. We want to work on the side that is underperforming to bring it up in value to oppose the higher functioning side. And if we can get both sides to function equally, what happens is they have a restoration of function, even while they're going through treatment, even while they have a diagnosis, or in spite of a treatment, in spite of a diagnosis, because we can have very similar symptoms of poor balance, vertigo, dizziness, nausea, aberrancies in gut function, heart function, breathing function, cognitive function from a head trauma in a super athlete that was perfectly super abled that 1 minute later after head trauma of particular forms is then disabled. So that's the same symptom profile in the absence of disease. And we've been working with these patients, for now a little over 20 years. And we use the same standards in patients with diagnosis to remodel and repair and rewire the central nervous system to its body to restore proper functioning. Okay, next, for the eyes, we'll have someone simply track. Can they track a moving target at different speeds in one direction versus the other direction? Then we'll have them hold gaze, which is, can you hold your eyes on a specific target? If they can hold, their eyes on a target to the right for half a second, but they can hold their eyes on a target to the left for 5 seconds, well, we know again, the integration of eye position, head position, and the ability to hold the eye in a desired task is incapable on one side, but not the other. Then all the therapy for visual exercise would be just to that integrated zone. And you get the eye to be able to hold gaze for 5 seconds one side as compared to its opposing side. And all of a sudden, maybe they can go back and enjoy reading. Maybe they can watch a movie again, not realizing these little parameters of inequality in the eye movement, eye ability to hold position, or speed of eye motion side to side is preventing the joys of being able to read without instantly feeling a headache or instantly getting dizziness or nausea, right? Or the ability to watch their favorite movie, maybe on Hallmark or something innocent, so that you can enjoy something that's hopeful and exciting without getting nauseous or dizzy. So again, isolating out where within the visual system the breakdown occurs in allowing proper function gives us the exact location to give all the treatment to just that area. So the third thing is very intimately, we'll ask patients with no target, and I find this one to be hugely informative, to just look straight up with their eyes at the ceiling. And this is your perceived trajectory in the vertical plane. And then I'll have them do the same thing of have them just shifting their eyes. Look to your left with no targets. Look to your left, look to your right, look to your left, look to your right. Can their eyes move horizontally on the x-axis evenly? Or when they go to the right, do the eye go like this? But when they go to the left, it stays level. And hence, if they were reading, every time their eye goes to a certain position of the page in this visual field, the eye is actually dropping down 1 or 2 lines and then coming back up, and they lose complete reading comprehension. We see this in a ton of children with learning difficulties. We correct those as well for them in these same parameters of care. Could they then immediately go back to reading and watching things and enjoy that? And it ties right into cognition, mental clarity, balance, gut function, nausea, and the way we feel about ourselves, and hopefulness, fear of falling, lifting. Okay. So we then take all these measurements and we put it all together into just one working plan. So we say with this patient, their trajectory when they look to their right, look like this, going down. So maybe we only exercise their eyes going up in that same reverse bell shape to mathematically cancel the trajectory error, which is pre-programmed in their brain to create the burst of activity to their eye muscles to move the eye in a position that's constantly in error. You correct that little error by an update using their own senses and just changing their eye position while it's moving in a pre-programmed position, and it updates very quickly. Oppositely, what if when they look up, their eyes actually go like this? So every time they bend their head down to maybe, blow their hair or brush their hair, or go up to do a shave or something like that, or to bend down to tie a shoe, or look up to get a can out of a cupboard, that their vertical eye trajectory is off without them knowing it. So every time they move in the vertical plane, they get really imbalanced. They feel like they're going to fall. They get very nauseated. They get their heart to change. They can get sweaty. They can feel their stomach getting bloated or irritated, and not knowing why, because vertical trajectory errors are mapped to the midbrain, and your midbrain is one of the primary motor systems to all the vasculature of your gut. So when we have a vertical trajectory error, if we don't correct for it without even foods, they can bloat for different reasons and get GI dysfunction and GI irritation throughout the day, from errors in the control center of the brain to the vasculature of their gut. And if that's constantly getting activated, one half the gut to the other half of the gut, one's getting a lot of blood flow, one's getting not enough blood flow, they're going to get, patterns of bloating, distension, and pain, which very shortly turns into gastritis, non-related to food, non-allergy, non-side effect of medicine. Okay, and then there's also all the effects of having gastritis and GI dysfunctions, from allergies, from, poor food choices, whatever. We're not talking those. We're talking purely here, neurogenic, brain-based gut symptoms, okay, brain-based nausea. So rather than having to rely on a life of Zofran and other things, for anti-nausea, what if we just balance their visual system? In this patient that we're making as our example, we do some fast-paced eye movements going up and right. We would then have them track in a bell going a little bit up and right to cancel that error going down. Maybe then we would do some patterns while they're staring here, rotating their heads slightly to restore their gaze holding abilities in that position. And then once they're feeling steady there, a few minutes later, recheck their balance. Are they still falling in the same head tilt or body posture as before? If no, wonderful. If yes, start isolating out the phenomenon of the inner ear and treat the inner ear through proper, balancing strategies. What would that look like? Those are strategies known as head-eye vestibular motion therapy. What would that look like? If I tilt my head like this and all of a sudden I fall, but if my head's like this and I'm stable, some people would say, well, just don't tilt your head. Nay. If you want your quality of life and confidence and reversal of fear falling, restoration of hopefulness, and good days are in front of you, you got to be able to move your head in all positions and feel stable. That gets you excited to feel better and leave, right? So if a person tilts their head to the right and loses their balance, we would do this therapy with them on their back. So they'd be lying flat on their back, and we would turn their head to that side. Remember, they're lying down, supine on their back. And we would then exercise their eyes in the same position where their eyes were inaccurate before that we just mentioned. So we're combining head, eye, inner ear, tilting the head to the part of the inner ear vestibular complex where they lose balance, vestibular motion, because we're doing the whole thing in movement, therapy to calibrate your somatosensory, your body, vestibular, your inner ear, visual, your eye. Remember, when those three systems talk with each other, one to one to one, we have a restoration of balance, stance, gait stability, reversal of nausea, dizziness, vertigo, mental fogginess, and often, without them even realizing it, or sometimes they do realize it, blurred vision gets crisp, non-related to the lens of the eye, which is their prescriptive index, but to the stability of the eye, that if without them realizing it, their eye has a little bit of a shake when they look in some positions. If the eye is shaking because it can't hold this position, then the world behind it is slipping on their retina, creating a distortion of their visual cortex. So when they produce the image to their brain for perception, everything's just a little bit out of focus, making them feel mentally foggy and a little bit unnerved without knowing why, because they're visually getting an error versus where they are in space versus what their body is telling them. And this is well known as a sensory conflict. And a sensory conflict exists in the brainstem between those three systems. And we've found that there's extraordinary therapies out there, and there's extraordinarily talented practitioners and therapists of all forms, all sizes, all types. We found that head-eye vestibular motion therapy hits an extraordinary home run, that what used to take us a year of therapies for patients to get stable in certain extreme circumstances can sometimes happen in days or weeks. And why? It's because incorporating the exact phenomenology within their exact nervous system to an exact treatment standard to properly integrate their information from their senses, from where they were deficient or impaired, back to the central nervous system, which is the brain and higher centers, back to their control of vital centers, back to their functions, which creates life restoration. Okay. And one last thing I want to talk on is many patients, for various reasons, and again, we see these with head traumas that get physically tackled or hurt in such ways that can get peripheral neuropathies from compression artifacts, or trauma, or people can get peripheral neuropathies from things of like a diabetes, either one or two, can happen over time. People can get them sometimes from hypertensive issues where it's undiagnosed and they have chronic hypertension for too long. Again, from various forms of toxicity or medications, and sometimes even certain chemotherapy agents are known to be more triggering to peripheral nerve irritation or problems than others. So what do we do with peripheral nerve problems? I'll share with you a new standard. So peripheral nerves are like the long telephone cables that connects areas from the brain and spinal cord out from the spine to its target tissue, whether it be your finger, your foot, your toe, your shin, your calf, your thigh muscle, et cetera, et cetera, et cetera. So we have peripheral nerves all over the body. We have them to control the fine motor and coordination of our muscles. And they create two basic forms of feedback. They communicate sensory of our limbs and our body to our brain. And also the peripheral nerves communicate motor signals from our brain's motor system through the spinal cord, through the peripheral nerve to our muscles. All right. And in doing so, they allow for the strength of muscles to hold our spine in certain postures. They allow the strength of muscles to hold our extremities in certain layers of control and postures so that we get coordination and fine motor activity so that we can do simple things that we could take for granted if we lose it, like grab a cup of coffee and drink it without spilling on ourselves. Because if a peripheral nerve was involved enough in our arms, maybe we don't have the strength to reach for the cup or the strength to hold a cup, or the coordination from the sensory and motor integration constantly communicating. The brain can coordinate the changes in position to drink and have this beautiful fine motor. So what we do is we map out what peripheral nerves are involved. Some people it's one, some people it's many. Some people it's not the peripheral nerves to their muscle, it's the peripheral nerves to their autonomic nervous system, which makes up a lot of, endocrine and organ function. So there's peripheral nerves everywhere. We map them out. We figure where they're impaired. And now they have nerve stimulators. Nerve stimulators are like a little device. It's about this big. It used to be a big push cart with an applicator one. It's now handheld, like half the size of a cell phone. And you can literally just put the nerve stimulator directly on the peripheral nerve where it's involved and start stimulating the nerve to electrically come back to life, like an extremely powerful form of exercise without any movement of the patient. So imagine they can't exercise because they're not stable enough to physically stand up and lift weights or get on a treadmill or ride bikes or whatever it may be. While they're lying down or seated, peripheral nerve stimulated directly on the peripheral nerve region, doing sets of 12 to 15 seconds. What you'll actually see as the peripheral nerve starts to send enough information through to the spinal cord, to the brain, back to the spinal cord, back through the peripheral nerve, you'll start to see contraction of the muscle as it starts to come back to life. Peripheral nerves can, in some cases are different and it cannot come back to life, but some cases that they can. And we find in the office, it's about half of people. So about half of people can have peripheral nerve improvement, right? Which gives them back their function, which gives them back a lot of quality of life. And some, it's been too many years where the problem has been there and it cannot be done. And we can figure that very quickly. It's either it's starting to come back to life or it's not, and we'll let the person know and they'll know it themselves. But as the peripheral nerve starts to wake back up and come back to life, then we'll start moving the mapped limb to that peripheral nerve. So what would that look like? Well, if it was the hand, maybe we're going to start, making movements of the fingers. Maybe we're going to start making movements of the wrist. Maybe we're going to start to make physical manipulations of the finger joints and the knuckles and the wrist bones and the elbow and the forearm and the shoulder to get all this joint information. Again, that's the somatosensory we spoke of, to feed back a richness of information through all the peripheral nerves in that area, to wake up the brain even further to its involved area and say, hey, hand, give me a little bit more function, give me a little more activity. I'm feeling all this electrical activity. You're feeding me back through this nerve. I love it. I haven't felt that in some time. For you loving me, I'm going to love you back and I'm going to give you more motor output from the brain. And all of a sudden, maybe we start getting back some movement or fine motor skill or coordination. And when someone was unable to be independent and you do some of these strategies and they are able to be independent, that is life-changing. And they may have the same diagnosis, but their quality of life went up. And they may have the same diagnosis and still be involved in the same treatment, but they have hopefulness because they saw their body change and improve, right? And again, I'm not talking about any individual diagnosis. I'm sharing newest standards of care that are now possible, that are physical means of using your own senses, your own body parts, your own involved reflexes, and what we currently know through neuroscience, how to remodel and repair the central nervous system to those mapped functions to restore quality of life. And when that can be done, wow, it's so exciting because you're doing it with using the person's own body, their own intelligence, their own structures, by really determining where it needs to go, doing it so specifically based on the phenomenology that we see and treating the phenomenology. And that is the new pedagogy of this standard of functionality in treatments of care, in all forms of diagnosis, in all states and conditions, in all states of dysfunctions. Because even within a diagnosis, there's so many variations of functioning. So if everyone gets the same treatment because they have the same diagnosis, we'd be missing the boat for so many in restoration of function. Oppositely, if we can accurately look at the phenomenology of what happens, they move their eye to the right, the eye dips like this. They try to look up, their eye goes in this direction. They tilt their head to this way and they fall, and we start putting all these simple observations into our program as the standard of care, that these were the phenomenon that are reducing their quality of life. And if we can reverse that phenomenon of the way the information is going to the brain in error, creating an error in output of control of the brain to its functions, then that person could have had a massive quality of life improvement while still going through the same treatment with the same diagnosis. And to me, that gets me super, super, super excited, because I firmly believe that there's hopefulness in any state, in any circumstance. It just looks different for each person, right? And that'll keep me excited forever. And it gets me super excited to show up and work my hardest every day. And my goal and my whole purpose of living is really to restore hope and reduce suffering in as many people as I can in a lifetime. And if I can do that, my life had purpose and value. And I'm willing to give my life to it. I've done 20 years already. And God willing, as many years as I can, I want to be of service to all of humanity. I went into doctoring because I love people. And everyone is someone's mother, someone's daughter, someone's wife or husband or best friend, a coworker. When you make just one person's life a little bit better, we've actually influenced multiple generations around that person, people that we don't even know. And doing that, and if we each can do that, to whatever degree that we can, we've made the world a bit better, a bit more filled with light, and a bit more hopeful. And those are the reasons that I doctor. So I think we're out of time. I can't thank you all enough for your attention and for giving me this privilege of speaking with such a beautiful audience today. And I look forward to, if you ever like me again, we'll do another presentation and we'll go more of a talk on hope and victory to really give some life examples of what can be done. Thank you so much. I wish you all blessed life.
Thank you so much. I think we have a couple of minutes for questions.
That would be great. Really great.
All right, thank you so much. I have something that's called perilymphatic fistula. That affects me. I'm high functioning, very high functioning. Affects me more visually, and I do a lot of visual therapy, eye therapy. And I'm just wondering, is there that much? And I've done vestibular training as well. Is there that much of a difference between your approach versus those other two combined approaches?
Well, I don't know. When you have a perilymphatic fistula, you're going to have a difference in rate function of the inner ear, one side versus the other. And what happens oftenly is, because that stays there, how do you compensate for it? We like to compensate around it by first mapping how it integrates into the brainstem and higher brain centers, and then figure out the exact integration to allow structures around it, like a different portion of the inner ear not affected by it, a different portion of the vestibular nerve, neck mechanics, spinal muscles of the neck, and aspects of the visual motion center to try to compensate for a little bit of the error that's coming from the perilymphatic fistula. so that we can create different types of compensation systems to try to compensate the nervous system that, although it has it, it's using senses in a way that it wasn't once designed to restore quality of life. Okay, so that's a very unique diagnosis, but yes, we treated that here.
Oh, thank you very much for your talk today. It's very informative. My question is, do you treat people who have benign positional vertigo, not with any other issues, no nystagmus or things like that, just a vertigo problem?
Every day. And we isolate it out between horizontal or vertical, and we treat it exactly. There's also an otolithic variant, and each one gets treated exactly for it is, and we treat that in all age groups. So in my practice here, you know, we see patients from infant through end of life. And why infant? Because sometimes there's troubles with birth, in utero, and other things. And if you can help rewire, remodel the central nervous system early, when they get older, they never knew they had anything. And it's quite profound. So the answer is yes, 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 and every day. That's one of the most common features that presents with vertigo or dizziness in all age groups.
And you work with acetazolamide sometimes with vertigo patients?
Say that one more time, please.
Do you prescribe acetazolamide for treatment for it?
I personally do not. I treat it purely physically using functional standards and non-pharmacy.
Okay, thank you very much.
Of course.
Do you deal with people who have other conditions such as Parkinson's and gastro issues?
Absolutely. So we have a number of Parkinson's patients at any time in the practice. And Parkinson's, again, we treat the phenomenology. So what we first do is we map out the basal ganglia and the subcortex. We see what is more involved. Is it more within the caudate, the putamen, the mesencephalon, the superior colliculus, the frontal lobe? And then we figure out how and where the communication within those motor system relays are affecting that person functionally. What that would mean: are they freezing? Are they having intention tremor? Are they able to move a little bit and then they freeze? You know, has their face changed? Are they having cognitive impairments from it? Are they falling backward? Are they leaning and looking all the way forward in like a canticormia posture? On and on and on. So there is a various phenomenology within that diagnosis, and we treat it exactly in each person. And what often happens is that they'll maintain the diagnosis, but their quality of life will be markedly better. That very often they can get by with either the same medication for many years without necessity to increase it because they're functioning so well and not having the normal decline year to year for at least some years, and or they're able to sometimes even reduce a little bit of the medication that they're using, because if you're functioning much better, sometimes there's less medical necessity. That's a very specific diagnosis though, because someone could be early in onset at 45, 50, or they can present for their first day of treatment here at 85 or 90. One can be on no pharmacy, one can be on polypharmacy, one can have 10 other comorbidities and diagnoses, one has nothing. So again, that's something that's treated exactly. And we've seen very nice things because we're doing it based on treating the phenomenology.
The question is, do you work with Lui Body Dementia?
We do, with various types of success. If the Lewy bodies are advanced and they're numerous, sometimes there's very little that can be done except grade, you know, for the family's well-being, you know, what their next couple of months may look like, just to give them some directionality. And sometimes you can improve them for some time. But the challenge when you have a frank pathology like that, where you're adding, you know, proteins into areas of the brain that are betraying your ability to think or cognitively perform properly, if there's too much protein laid down, sometimes it's impossible to navigate around it. And sometimes it is possible. Again, it depends to the degree and how early you get to them. I would encourage anyone in any of these diagnoses that we mentioned and others, the faster you begin this form of treatment, typically the better the outcome. It's the same with head trauma. I want to get to people as fast as possible with head trauma before they wire neuroplastically aberrancies in their healing. Let's put the proper inputs in so that as the brain heals with neuroplasticity, they're wiring correctly so they don't end up with post-concussion syndrome or post-traumatic syndromes, okay?
thank you so much for speaking with us today. And you are so knowledgeable.
Oh, it's
And thank you for taking the time to answer everyone's questions as well.
Thank you, Dr. Leon.
Thank you.
Oh, you're all so wonderful, and thank you so much. And I'm a prayerful man, so I'm going to pray for everyone that tomorrow is better than today, and the day after is better than the day before. And even if we go to bed some nights suffering, to have hopefulness that tomorrow the sun can come out again. All right, love to all of you and your families, and I hope we meet again.